Welcome to AETCM channel. Shall I start? 34-year-old male patient, no known comorbidities, who occasionally smokes, presented with complaints of pain and numbness over the left leg and foot for the past 2 weeks, that is worsened for 2 to 3 days. On initial 10-second assessment, patient conscious oriented and obeying commands. Primary survey, airway was patent, talking in full sentences. Coming to breathing, SpO2 is 99 in room air with respiratory rate of 18 per minute, bilateral air entry equal, circulation BP is 160/80, heart rate is 106 per minute. And coming to peripheral pulsations, femoral, popliteal and dorsalis pedis and posterior tibial artery is palpable in the right lower limb, and dorsalis pedis and posterior tibial artery is not palpable in the left lower limb. And GCS is 15/15, pupil is 2.5 mm equal and bilateral reactive. GRBS is 141 and temperature is afebrile. Coming to ambient history, 34-year-old gentleman presented to ER with complaints of acute onset pain in the left leg and foot 2 weeks before, which is progressive in nature and worsened for the last 2 to 3 days. In initial days, it is partly relieved by rest, but now pain in the foot persisting even at rest and partly relieved hanging the legs over the bed. He also complained of mild numbness and paresthesia over the left foot. There is no restriction of movement to the toe, ankle, or weakness of the leg, slurring of speech, headache, chest pain, palpitation, or trauma to the limb. On local examination, there is no pallor, cyanosis, edema, or lymphadenopathy. Right leg, normal color, normal temperature, or peripheral pulsations are palpable. There is no scar marks or wound seen on palpation. On left leg, there is no pallor, but tenderness is present in the left leg. In the lateral aspect of the left foot, and cold peripheries compared to the right leg, and femoral and popliteal pulses are palpable, but dorsalis pedis and posterior tibial artery pulsations are not palpable. Mild pain is present in the passive movements, no motor weakness, mild numbness over the dorsal aspect of the left foot, the rest all sensations are normal. We done investigations like.
So at this point, what is your differential diagnosis?
Peripheral arterial disease now present, acute limb ischemia state.
So why you are saying peripheral arterial disease?
There is previously the patient has no as such no pain history.
Any claudication history?
No claudication history.
No rest pain. Young patients.
Yes.
Smoking history?
Occasionally smokes.
Occasionally. So occasionally is not. When we say peripheral arterial disease, what we are indirectly saying, there is a atherosclerotic arterial disease. That's what we are telling, isn't it? And atherosclerotic arterial disease is a systemic disease condition. It's not a limb disease condition or a localized disease condition. It's a systemic disease condition. So two common comorbidities you need to mention for atherosclerotic arterial disease is type 2 diabetes and smoking history. Okay, these are the two. Heart disease is a consequence of atherosclerotic disease. Okay, so these are two things. Not a diabetic, not a chronic smoker, no history of claudication or rest pain. So you can't say this is a peripheral arterial disease. Okay, this is acute limb ischemia. Okay, but patient symptom has started 2 weeks back. So now it has become subacute limb ischemia. Okay, but acute limb ischemia as such. That is your primary diagnosis. Fine. What else? Let me simplify it for you. You are having difficulty because you didn't get pulses, right? You got pulses. For example, this patient presented with left, right?
Yes.
Left lower limb, 2 weeks history of pain associated with mild sensory loss in the foot region. For last 2 days, pain has worsened with the worsening of sensations in the foot region, which is anteriorly increasing, and there is difficulty in walking. This is your history. Examination, we are getting all bilateral lower limb, all pulses are present, isn't it? What are your DDs?
Postoperative compartment symptoms.
Compartment syndrome. Okay, compartment syndrome is a good differential diagnosis for acute limb ischemia. What is the problem? This patient doesn't fit. This is a 2-week history. So by this time it would have gone into compartment syndrome and necrosis. So this patient doesn't fit. But acute limb ischemia, one of the differential diagnoses is compartment syndrome. Correct. What is the main difference between compartment syndrome and acute limb ischemia?
Pulses will be
In severe compartment syndrome, even arterial pulses can be suppressed. So you can't say pulselessness as the only feature. What is the main complaint? What
pain
about
on
pain?
passive movements.
Yes. Compartment syndrome, usually patient has exacerbation of pain on any movement of the muscles, active or passive. Initially it will be passive movements of the limb, and finally it will be even in active movements there will be, initially it will be on active movements of the limb, and towards the worsening of compartment syndrome, even on passive movements you will get pain. But acute limb ischemia, pain will be persistent because the pain is secondary to nerve injury. Ischemia to the nerve is causing this. Because of neuropathy, pain will be persistent. Okay, what else? Other than compartment syndrome, what else other DDs can you tell about acute limb ischemia? Oh, sorry, acute limb pain with sensory loss and difficulty in walking.
Acute trauma.
Neurogenic causes. What neurogenic causes? Yes, not spinal canal stenosis. Spinal canal stenosis is a chronic condition. Stenosis, chronic condition. You need acute stenosis or acute reduction of spinal canal diameter. So that is
trauma and
trauma-induced spinal canal injuries or trauma-induced vertebral fractures, or if it is not trauma-induced, IVDP.
Disc bulge.
Yes, IVDP. IVDP above the level of L2 will definitely cause similar complaints. Patient will have pain, worsening of pain, but that will be usually on movements. At rest, patient will be pain free. Patient can have sensory losses, usually will be patchy sensory losses if it is below L2 level. Above L1 level, you will get a sensory spinal level, isn't it? Then you will have motor weakness. What will be the differentiating factor? First is, as you told, pulselessness. In the acute limb ischemia, you will have pulselessness. Here, pulse will not be as such affected. What else? Usually bilateral. If the trauma induced and IVDP usually will be bilateral, but it can even be seen unilateral. If it is not completely occluding into the spinal body, only on the one side it is affecting, it can be unilateral also. What else can be there? Any other differentials? Similar to compartment syndrome, but not due to trauma, due to something else.
Cellulitis.
Cellulitis will not have any sensory loss as such, no? Severe DVT. Severe DVT, since venous occlusion is there, fluid, the increase in fluid compartment in the compartment will increase on pressures. So, deep vein occlusion, superficial vein occlusion will cause significant rise in limb pressures causing arterial occlusion, which is very rare. Phlegmasia, isn't it? That can be there. These are the commonest. But acute limb ischemia is very, very easy to spot, because usually acute limb ischemia of very acute origin will be associated with pulselessness. So, what are the clinical features of acute limb ischemia?
Pain, pallor, paresthesia, and cold peripheries, pulselessness, paralysis and pulselessness.
So, 6 P's. Pain, neuropathic pain. Pallor due to decreased blood flow to the limb. Poikilocytosis, that is reduced temperature to the area. paralysis due to loss of power due to reduced blood supply, paresthesia due to nerve injury, and pulselessness. Okay, this is the classical features. In all acute limb ischemia, should you get the 6 P's? So what are the variations in which patient can present?
Mainly with passive pain and like in there is a classification like Rutherford classification with the category 1, the patient with a viable limb. So the pulsations are all present, only presented with pallor or there is no sensory or motor deficits. But in category 2, that is category 2A and 2B, both are threatened limb. One is minimally threatened and 2B is immediately threatened. In minimally threatened, there is no motor or sensory deficits, but in immediately threatened, there is partial motor deficits. And in category 3, there will be motor and sensory deficits with nerve damage and ulcerations will be present in category 3. These are the presentations.
Fine. So basically, one of the presenting features for the patient will be pain and progressively loss of temperature. Then loss of pulselessness will come. Once loss of pulselessness comes, then only our paresthesia, paralysis and painness will come. So unless pulselessness is present, patient may not have all 6 P's. But persistent symptoms will be acute onset of pain and reduction of temperature. This will be there. So what are the different types? We have complete arterial occlusion and incomplete arterial occlusion, isn't it? So this depends on the artery state. Are we dealing with a normal artery which is getting occluded or already diseased artery which is getting occluded? That is acute limb ischemia on peripheral vascular occlusive disease patient, PVOD patient, or acute limb ischemia of a non-PVOD patient like this one, isn't it? So what are the most common causes for acute limb ischemia in a PVOD patient?
Already the thrombus get ruptured.
Thrombus in the atherosclerotic plaque due to the plaque rupture. Then worsening of disease. What else?
Any other rheumatic plaque get embolized.
Embolization of already ruptured atherosclerotic plaques. Now, what about non-atherosclerotic diseases? Usually it will be embolic in nature, isn't it? There is nothing there to cause thrombosis as such. So in a native artery occlusion, a patient like our patient who doesn't seem to be atherosclerotic disease patient, it is called as native artery. So native artery occlusions are predominantly embolic in nature. So where does the embolic comes from? What are the other conditions of embolization you should suspect?
Atrial fibrillation.
Atrial fibrillation. What other cardiac condition can cause embolization? Infective endocarditis, MI, then atrial myxomas, not only infective endocarditis, replaced valves, mechanically replaced valves can cause thrombosis and embolize. Then what else can? Vasculitis is there, but cardiac complication as such. One more, severe LV dysfunction can cause. These are the most common cardiac. Okay, then what else? One more thing, paradoxical emboli. Patient is having a FO, foramen ovale. Patency is there. A DVT can embolize into the systemic area. Very rare, but these are the cardiac complications. Now, non-cardiac complication. Non-cardiac variantal emboli can form due to vasculitis. Most common vasculitis, giant cell artery arteritis and Takayasu's arteritis. These two conditions can cause arterial embolization as such. What other condition can cause embolization or thrombosis? All carcinoma patients. Carcinoma patients have increased chances of producing thrombus. Most commonly venous thrombus, but arterial thrombus can also be there. What other causes are there? Increased clotting tendency patients, thrombophilia patients. Due to clotting factor hyperproduction or increased sensitivity, patients can develop these things. These are the conditions in which patient can come with native artery embolizations. Okay. Now, once this embolization happens, how the patient presents is the clinical part we told. So, patient can present with 6 P's. We told at least pain and loss of temperature should be there. Okay. So, what do you think? Which type of patients will have more dramatic presentation, or who will be more symptomatic? A native artery thrombosis patient, a native artery patient who presents with acute thrombus, or a PVOD patient presenting with acute thrombus?
Native artery with acute thrombus.
Native artery patient with acute thrombus will have very acute onset, very severe symptoms, and most probably that patient will go into acute limb ischemia. Why?
In the chronic situation, there will be formation of collaterals.
Yes. In a PVOD patient, since the main artery is blocked, there will be formation of collateral arteries. So, since the collateral artery formation is already there, the limb ischemia part may be delayed or may not even happen. So, in a PVOD patient with acute limb thrombus, the main artery that is getting thrombus, patient will always complaining of a worsening of symptoms, but you may not get all the features of limb ischemia. Okay, and the pulselessness will already be there secondary to the PVOD. Okay, so in a PVOD patient presenting with worsening of symptoms, acute limb ischemia can be missed, since you may not get the 6 P's of limb ischemia. But you should consider any PVOD patient presenting with acute worsening, any increase in pain or difficulty in not improving with the rest and all, acute onset is there, you should suspect acute limb ischemia, even if all other 6 P's are not there. But in other patients, you will definitely get. And once limb ischemia features are set in, your gradation will come, whether the limb is non-threatened or threatened. Is it viable, and is it minimally threatened, moderately or severely threatened? Okay. So, non-threatened means what? There is no ongoing ischemia to cause severe cell death or loss of tissue as such. There is ischemia there, but it's not significant enough to lose a limb. Okay. What does that mean? That means you have time for evaluation. That is the whole thing. What should be done? What is the evaluation for acute limb ischemia? What are the investigations?
We do the arterial Doppler for that. And arterial Doppler, if it shows monophasic flow, there is reduced blood supply to the, shows reduced blood supply. We can also do CT or MRI angiogram if there is time.
So, you have supportive investigations and diagnostic investigations. Diagnostic investigation is basically radiographic investigation. The minimum that you want is a pulse wave arterial Doppler. Okay. So, minimum, the bare minimum you want pulse wave arterial Doppler, in which if you are having absent arterial pulse waves, you can diagnose a patient to have acute limb ischemia with acute arterial occlusion. Okay. But the level of arterial occlusion or the extent of arterial occlusion cannot be assessed with a pulse wave Doppler. Okay. Pulse wave Doppler will also help you to identify whether there is a venous occlusion also. That is pulse wave arterial Doppler, primary diagnostic criteria. But the gold standard is arteriogram, peripheral CT arteriogram. So, arteriogram will tell you what is the level of occlusion, what is the extent of occlusion. So, how much length of the artery is occluded, and what are the other most important details a arteriogram will tell you. Whether there are collaterals, so whether the limb is salvageable, non-salvageable, whether there is collaterals, whether the patient is a candidate for bypass grafting. All these informations you will get from a CT aortogram. Now, why we told this is because this is how we have to, this is a decision we take according to your classification. So, any patient who is not having any threatened limb, that is viable limb or minimally threatened limb patients, we can go ahead get a CT arteriogram. So, because the idea is planned procedure to improve ischemia, improve blood flow and save the limb. While threatened limb, limb is 2B, right? 2B.
That is
minimally threatened and
2B is immediately threatened.
Immediately threatened. So, in minimally threatened condition, you have time for diagnosis, but patient requires emergency intervention in the form of anticoagulation and endovascular process. And in severely threatened,
in category 3, if it is not possible to revascularize, if it is revascularized, there will be free radical injury and more damage to the limb.
So, the limb is completely ischemic, and due to the ischemic, there is already lot of inflammatory products in there, and a revascularization cannot be done because limb is already gone, is lost. Because of that, the treatment will be go for a amputation. So, even in that case, there is no point in going for a diagnostic testing. The only testing that is required is for supportive for amputation. So, in that condition, that is severely threatened limb, if you are going for CT arteriogram, what is the information you are looking for? You are looking to see at what level you can ampute. Means then the question is, at what level we can ampute, which will promise a good healing of the tissue. That is the information you are getting from CT arteriogram, not about the vessel status as such. So, if for example, however below distal the amputation is, that much functional improvement for the patient. To know the distal level, you need to get a arteriogram. Okay. So, this is diagnostic testings. What are the supportive testings you can do? Bedside testings or other investigations you can do?
We can do the complete blood count
Okay.
for looking for any polycythemia that will lead
Correct.
to stasis.
So, that is not for infection. We are looking for polycythemia or increased HB levels. HB levels, platelet abnormal HB platelet levels we are looking for. Then
we can also look for ABG for any acidosis changes. If it is in muscle ischemia necrosis, if there is any acidotic changes, we have to rehydrate the patient.
Okay.
We can also look for CK levels also for this muscle
Then total CK levels. What else? Urine?
Urine myoglobin.
Urine myoglobin level. So, total CK, urine myoglobin to rule out muscle injury. Then
also look for electrolytes and
what electrolytes are you worried about? Potassium. But that is severely threatened limb and usually not in acute presentation over time, because as the necrosis worsens, more potassium. But what in supportive investigation is very important, because right now we were talking about ECG. Yeah, one is source of infection. Is there a emboli? So, cardiac evaluation is important. So, ECG taking is important. Similarly, serum creatinine. You want to, your plan is to go for a arteriogram. To go for arteriogram, you want to know whether kidneys are
functional.
There is renal failure or not. Because if renal failure is there, it's very difficult to go for arteriogram, isn't it? These are supportive. Okay, what is a bedside investigation which can help you in identifying acute limb ischemia? For example, like non-threatened limb. Okay, non-threatened limb is category 1, right? Patient is having pain. There is mild, there is pain, persistent pain, rest pain, but there is no sensory loss. Your pulse may or may not be palpable as such. That is your minimally threatened limb. What bedside investigation can you do to diagnose it as acute limb ischemia? Will blood pressure help you? What is that?
Angle pressure.
Angle?
Angle brachial pressure index will
Yeah, ABI, Ankle-brachial index. What is Ankle-brachial index?
the difference between the pressure in the ankle and the brachial part.
Brachial arteries.
Brachial arteries pressure difference. If
Okay.
it is less than 0.9, then it's acute limb ischemia. If it is less than 0.4, critical limb ischemia.
So basically, it is a division between the lower limb systolic blood pressure by the upper limb systolic blood pressure, right? Okay. So values are less than 0.9, 0.9 to 1.3 and more than 1.3. This is how it is classified. Now, how will you take ankle-brachial index?
Make the patient rest, lie down for 15 minutes. And
Why?
we want to take this.
The idea is patient shouldn't have just walked in, because with exercise ankle-brachial index will vary. Okay, so patient should have rested at least for 15-20 minutes before you take ankle blood pressure. That is the idea. So at least make sure the patient was resting for 15 to 20 minutes before starting the test. Okay, then
measure the blood pressure of the both limbs. Ankle pressure should be measured either using dorsalis pedis or posterior tibial.
No, you should measure both. You should, once you tie your sphygmomanometer cuff in the just above the ankle joint, you should measure blood pressure from both the dorsalis pedis and posterior tibial, because patient can have atherosclerotic disease of single arteries also. For example, patient can have single artery atherosclerotic disease and diffuse artery, and in diffuse also certain arteries may be more affected than certain ones. So you don't know whether tibial artery is more involved than dorsalis pedis or not. So you should take systemic blood pressure of both dorsalis pedis and posterior tibial and take the highest systolic pressure of either one. For example, you are having a systolic pressure of 140 in DP and 132 in PT. 140 is what you should take into. Okay, then you should compare that with the other limb, supposedly normal limb, and see whether this is increased. And then you take your brachial artery normal blood pressure as such. How will you check these blood pressures? You tie it, inflate it and auscultate. No, you should use bedside arterial Doppler. Okay, only thing you want is a systolic BP. You don't want diastolic BP. So there is no point in auscultating. You want arterial Doppler, because auscultation is subjective. In severe PVOD patients, auscultatory blood pressure may be very much misleading. You can't use that. So you need arterial Doppler. So you place the arterial probe over the affected artery, inflate the cuff and inflate till you cannot hear the Doppler sound of the flow. Okay, once the flow is completely stopped, that is, there is no Doppler sound coming, you slowly deflate the cuff till when you start hearing the Doppler note again. Once you are hearing the Doppler note, make a note of the blood pressure. That is a systolic blood pressure. Okay, similarly take for DP, PT of affected limb, normal limb, and take the systolic BP of the upper limb. All are with the arterial Dopplers. Okay, now what you do? Take the highest of the systolic pressure of PT or DP and divide it with the systolic pressure of the upper limb and see how much it is. Less than 0.9 is very sensitive and specific to acute limb ischemia. Okay. Less than 0.4 is severely limb ischemia. Severe limb ischemia. Okay. So what if it is 0.9 to 1.3? We told 0.9 to 1.3 is normal. Okay. But patient is having pain. Patient is having some amount of rest pain is there. What will you do?
We will give analgesia and will analgesia support, and we will give further investigations will be.
Yeah, that is there. But in ankle-brachial index, you get a patient in which you are suspecting limb ischemia, but your ABI came back as 0.1, came back as 1. which is within acceptable range, right? So what will you do? You should do a exercise test. You should ask the patient to go for a walk or take a walk, so for 10 to 15 minutes. So after exercise, you recheck ABI again. So after exercise, what will happen? Since there is already limb ischemia, the limb blood pressure should fall from earlier. So a more than 20% fall of systolic blood pressure of affected limb is there from the previous, you can diagnose. Or after exercise, if your ABI score is less than 0.9, you can say there is limb ischemia. Okay, so if you are suspecting limb ischemia, your ABI value is between 0.9 to 1.3, you should do a exercise test and recheck the value. More than 1.3, what does it mean? There is a non-compressible artery. Basically, we are saying most probably there is a atherosclerotic or calcified artery there. That means you have to go for arteriogram. You can't use ABI to diagnose limb ischemia there. Okay, so why I told this is ABI is not completely believable in case of acute limb ischemia. It can be only helpful if ABI score is less than 0.9. So if you do ABI, and ABI should only be done in minimally threatened or non-threatened limb. In threatened limb, do not go for ABI. Okay, patient symptoms will worsen, you may not get a positive thing. So in non-threatened limb or minimally threatened limb, you do a ABI, score less than 0.9, good, you are diagnosed. Your specificity is 100%. But if you not getting a positive ABI score, don't think that patient doesn't have limb ischemia. You have to either do a exercise test or go for arteriogram. Okay, so once you diagnose this to have acute limb ischemia, how will you manage this patient? What is the immediate management?
The anticoagulation.
Immediate management is analgesia. Patient is having severe pain. So analgesia is the immediate management. After that, what is the proper management? Anticoagulation. How do you anticoagulate the patient?
Injection heparin.
The most commonly used is unfractionated heparin. What is the dosage?
5,000 sub-Q stat.
5,000 international units sub-Q stat. Okay. What if there is acute limb ischemia on a native artery with moderately threatened limb? Is it still 5,000 units sub-Q, or do you start any infusions with heparin?
Heparin infusion.
Tell it's okay.
Dose therein.
Okay. In acute limb ischemia, in arterial, there is no infusion dose. It is 5,000 international units sub-Q. But what else can you give in acute limb ischemia? Other than anticoagulation, what is the second thing you will start? You have to lyse the
thrombolysis. Streptokinase injection.
Tell that. You can give streptokinase or recombinant TPAs. What are the recombinant TPAs? What is the one thing? Tenecteplase. Commonly used is alteplase. Okay. FDA approved is alteplase. Tenecteplase is not FDA approved, but certain centers use tenecteplase, certain centers use alteplase. So alteplase, what is the dose that you will give? Similar to MI. Similar to MI. 10% start followed by 90% over 1 hour infusion is what you give. But in any immediate limb threatening is there, alteplase has to be started. There is no heparin continuous anticoagulation. It is alteplase. Okay. So in centers in which alteplase is not available, you can use streptokinase also, but thrombolytics should be given for the patient. Fibrinolytics should be given for the patient. Okay. Once that is started, what else is your next plan? One thrombolysis or fibrinolytics is started, what will you next plan for? Plan for arteriogram. Arteriogram to see whether a endovascular procedure is required or not. So arteriogram shows a emboli and it can be retrieved, endovascular procedure can be planned. If not, you admit, assess the patient and look for improvement. Okay. What else is there? Anything else is there? Okay.